Olá a todos, bom dia, estão bem-vindos a mais uma Osteotalk. Desta vez vamos falar com o Dr. Raymond Perrin, é osteopata, é doutorado, especializou-se nas áreas do sistema nervoso central, na drenagem do sistema nervoso central, no sistema linfático, na intervenção osteopática, nos síndromes da fadiga crónica, nas fibromialgias, nas encefalomielites miálgicas. E, portanto, é um especialista nesta área, é autor de um livro, vai sair um outro livro também em setembro, The Perrin Technique, e vai sair um novo livro, uma revisão deste livro com novos dados científicos. O primeiro livro foi em 2005, salvo erro, 2007, e portanto vai sair agora uma nova edição com novos dados que corroboram no fundo esta área de investigação do Dr. Raymond já desde há anos. Vamos passar então à conversa com o Dr. Raymond.
Hello, Dr. Raymond Perrin. Good morning. Nice to meet you. Nice to see you. Thank you so much for accepting our invitation.
Good morning, Bruno. Good morning.
Good morning. How are you? I know you've been very active during this pandemic stage with patients, and which kind of correlates with what we're going to talk about today, which is chronic fatigue syndrome and myalgic encephalomyelitis and fibromyalgia, which you're a PhD in specialized in these areas, in this field, and in the drainage of the central nervous system. So you have a presentation for us, and I can't wait to see it. Thank you.
Okay, thank you very much, Bruno, for having me on your talks. As you say, we've been active the whole time. We haven't closed one day during the whole pandemic. One of my roles is international faculty lecturer for the Osteopathic School of Deutschland, OSD, and I have lectured to undergraduates on the immune system, immunology, and lymphatics, as well as chronic fatigue syndrome and fibromyalgia. So I'm quite knowledgeable in this field, having a PhD in more in the neuroscience behind the side of chronic fatigue syndrome, ME. But it is very relevant, as you say. It is extremely relevant now because after a virus such as coronavirus that has affected a person, many people will have a post-viral fatigue syndrome, as chronic fatigue syndrome used to be called. And basically, what we can do is help the patient recover quicker from this post-viral fatigue. And we're seeing already post-COVID-19 syndrome cases coming into the clinic, and patients with a pre-existing condition are definitely getting worse because of the virus, and therefore we set our targets to help all the patients, desperate patients who are getting worse, and we have personal protection. I wear a mask, a shield, the complete protection, and we give the patients masks to wear during this crisis. So we are very busy, and I do have a patient in about 40 minutes time. So on with the show. Chronic fatigue syndrome, what is it? Well, you know, people always suggest it's getting tired. Life is one long process of getting tired, as Samuel Butler said. So what's special about chronic fatigue syndrome? Well, what I'll be teaching, hopefully, in a much longer seminar, we hope in the future, when I come over to Portugal, hopefully, when all this is over.
Let's hopefully at the end of this year. Let's hope. Let's hope.
Well, hopefully, yeah. We will be teaching the applied anatomy and physiology of the sympathetic nervous system and lymphatic systems to understand this. The basis of this is looking at the spine. As we're osteopaths, we always start with the spine and go out from there. And looking at the spine, you see in this patient who's got chronic fatigue syndrome, there's a kyphosis in the upper spine, a flatness in the middle part, and there's now the kyphosis in the bottom part of the thoracic area. And this is a pattern we see again and again and again. And for those of you who are experienced osteopaths will say, well, we see all this all the time. This is classic osteochondrosis that has happened during teenage years. Yes, it is. And you see this in many cases. However, with chronic fatigue syndrome, we see a problem in the thoracic spine in all of the patients. This is one of the physical signs that I've discovered, that they all have thoracic spine problems if you look at the posture. And Irving Core, who most osteopaths have heard of, suggested that spinal dysfunction would lead to disturbances, muscular fatigability, sensory excitability, immunological mechanisms, endocrine functions due to sympathetic efferent impairment. And this was in those days, in the 70s, Core, when it came out with his theories, everything was efferent, everything was going to the organ from the central nervous system, and therefore there must have been a problem in the efferent flow. However, nowadays we know much more, and Yannick, who's one of the leading neurophysiologists involved in the osteopathic profession from Kiel University in Germany, Professor Yannick has said that together with Frank Willard's work, and most of you have heard of Professor Frank Willard from the States, that the sympathetic nervous system basic influence is more afferent, is more the sensory component coming into the brain. So when we actually treat, as osteopaths, when we treat the body, we are reducing this the afferent flow into the brain that's causing a problem to the nervous system. We're dampening it down, we're calming everything down. This is what we do as osteopaths. Fibromyalgia is interesting because we talk about fibromyalgia, and in my workshop I'll be showing that the old tender points that were always used to diagnose fibromyalgia have been thrown out quite a few years ago. In fact, 10 years ago, in 2010, the American College of Rheumatology, who developed these 18 tender points, and if you have 11 out of 18, it was used to diagnose fibromyalgia. These aren't applicable today, because we know that a lot of doctors and practitioners were pressing too hard, and everybody was being diagnosed as fibromyalgia. Some were pressing too soft, and nobody was being diagnosed with fibromyalgia, and lots of them were getting the wrong points. So what we now know is that from 2010 that we look at it a different way, and fibromyalgia is very similar to chronic fatigue syndrome, ME, with widespread pain in all four quadrants of the body. So pain is the main significant difference with fibromyalgia and ME. With chronic fatigue syndrome, ME, you have fatigue as post-viral fatigue or post-exertional fatigue, as the most important aspect. And there is also pain. Pain is ME stands for myalgic, muscle pain, and then encephalomyelitis to do with the brain and the spinal cord. And sometimes there's not even inflammation there. So myelitis sometimes sometimes people refer to ME as myalgic encephalomyelopathy. But when you have widespread pain in all four areas with the symptoms of CFS-ME, fibromyalgia is usually diagnosed. And what is actually going wrong? If it's all to do with afferent supply, sensory nerve components, where does these sympathetic nerves, where do they end up? And if you go into the brainstem, you come to an area called the locus coeruleus, which produces a lot of noradrenaline, norepinephrine, and you then go further up, and they've got the main center of sympathetic control of sympathetic and parasympathetic control, the hypothalamus. Hypothalamus is the main regulator of the autonomic nervous system. It's also the main regulator of hormones, as we'll see, which is very relevant in this illness. But let's look at the lymphatics very, very briefly, as we'll deal with this much more in a proper workshop. The lymphatics were first discovered quite a few hundred years ago by Italian Gasparo Aselli in Milan, and he called it lacteas venus, which is actually interesting, milk veins. So one of the things you know about this is because he said it was creamy white vessels, you know for sure, for absolute sure, he was looking in the gastrointestinal system at the time, because that's where the lymphatics are creamy white. They have the fluid is called chyle, and the rest of the lymphatics is colorless. The lymph fluid is just lymph, which is a colorless fluid. But in the gastrointestinal system, it's chyle, and the chyle is creamy white. So he discovered the lymphatic system, and we knew about the lymphatic system as osteopaths from day one. You know, Andrew Taylor Stills talked about the lymphatic system very, very in much of his work. He mentioned the importance of the lymphatic system. But the interesting historical side of Andrew Taylor Still is he was a doctor in the American Union Army during the Civil War. He turned coat to the north. He was a humanist and an he was an abolitionist. He was an anti-slavery, which in this day and age is very, very relevant. He would have taken the knee and joined the human rights activists. And at the same time, Jacob Mendes da Costa was a doctor in the American Civil War as well, from Philadelphia. He was in the Union Army, and he discovered that a lot of the patients, a lot of soldiers were coming down with what he called irritable heart disease, or soldier's heart, it's also known as. And he found that it was the nervous system affecting the heart and the lungs that was being affected. And this was sympathetic nerves, was being overloaded by the stress and strain of the very emotionally turmoiled war, being a civil war. And he came up with da Costa's syndrome, which was one of the first recorded listing of symptoms that we now call chronic fatigue syndrome, ME. However, the psychiatrist took over the work, and Jacob da Costa went towards the psychiatric side, and his syndrome eventually became known as post-traumatic stress disorder, which is different to ME. But da Costa syndrome was one of the first recorded mentioning of all the list of symptoms that we call chronic fatigue syndrome nowadays. And in the 20th century, it was called effort syndrome by Sir Thomas Lewis in the UK. And in recent times, the Gulf War syndrome, the first Gulf War. So there was a lot of people coming down with this post exertion malaise and all the symptoms that we see with chronic fatigue syndrome. So what's the combination? It's a stress. What's the common link? Is a combination of physical, emotional, and chemical stress. American Civil War, they stockpiled chemical weapons. They didn't use them, gas, mustard gas and things, but they had them there. In the First World War, they used it. Mustard gas and chlorine was used. So there was chemical damage. In the Gulf War syndrome, in the first Gulf War, the Kuwait was on fire, and the petrochemical chemicals were terrible. But also the soldiers in the Gulf War, soldiers wore kit which was infused with organophosphates because they were anti-parasitic, and there were pesticides sprayed onto the kits to stop them getting sandfly disease. So there was a lot of chemicals there, plus they had immunization going on for the weapons of mass destruction that nobody ever found. And the emotional side of the wars were great, as wars always are very stressful situations. And the physical side, they're all carrying heavy weights and heavy kits. So this led to a lot of patients getting ME, chronic fatigue syndrome, and fibromyalgia after these events or during these events. So what's really going on in the brain? This is what we'll be discussing much more in length during workshops. But basically, we have to look at the circumventricular organs. The organs such as besides the hypothalamus, where the organ vasculosum and median eminence are. There's a pituitary gland, there's a pineal gland, there's other areas in the brain which are surrounding the ventricular system and and closely connected to the point where hormones can enter, because these are areas of the brain where the blood-brain barrier doesn't stop large molecules entering. That's the blood-brain barrier stops any major large molecule entering the brain, and this is why we don't officially need a lymphatic system for the brain. However, the circumventricular organs don't follow that rule. They have a very weakened blood-brain barrier, and this weakened blood-brain barrier leads to major major problems, because as well as hormones entering the brain in this area, toxins enter the brain, and especially the hypothalamus, which is connected to all these other organs as well. So it has an overload when large molecules of toxins enter the brain in this area. So the blood-brain barrier is not a very good barrier, really. And this is where we need a system. We need the lymphatics. What are the lymphatics for? Therefore, the larger molecules. Small molecules can go through the walls of the capillaries, the blood capillaries. They filter the small molecules through. However, large molecules can't get in, so they need another system. And this is where the lymphatics come in. Their molecule, their capillaries, which we'll be talking more in depth in workshop, basically open and close like gills of a fish in a way, and they allow large molecules into the capillaries of the lymph, and then they drain eventually into the bloodstream, and eventually into some go into the bowels and come out through the skin and come out through the waterworks. But eventually a large part of it will end up in the liver, where they get detoxified and broken down. So the lymphatics is very important for the large molecules, but there isn't officially a lymphatic system in the brain, or is there? Andrew Taylor Still did say the waters of the brain drain to the lymphatic, so he knew there was a connection between cerebrospinal fluid and lymphatics. So let's look at what's actually happening with ME, with chronic fatigue syndrome. We know there's multiple immune hits or massive immune hit sensitizes the microglia of the brain. The microglia, the glial cells, maintain a hypersensitive or prime state. Then there's a triggering effect. So the problem is there already. There's this hypersensitive state, and this is the work of Professor Jared Younger, who was at Stanford University, is now at the University of Alabama. He's a neuroscientist who's looked at the ME as a neurological condition many years ago, and he's come up with similar conclusions to myself, that there's a triggering event, infection, stress, poor sleep. And this activates this hypersensitive microglia. Microglia are then transitioned to a pro-inflammatory state. There's lots of cytokines forming there, and we know at the moment with COVID-19, there's a lot of cytokines involved, causing cytokine storms, and this causes a problem. The microglia produce multiple pro-inflammatory, excitatory or neurotoxic factors. And then these factors eventually lead to a complete disturbance of other neurons, which lead to CFS-ME and fibromyalgia. And the difference between CFS-ME and fibromyalgia is where in the brain is more toxic, more overloaded with inflammatory toxins and other toxins. And the brain is a very, very vast organ. People don't underestimate the brain sometimes, but there's 100 billion neurons in the brain. 100,000 million neurons in the brain, with trillions of synapses, and the chemicals involved in this exchange are vast, and there's millions and trillions of interactions all the time. And therefore, any toxic overload in different areas of the brain will cause different symptoms for every patient. So every patient with chronic fatigue syndrome, ME, every patient with fibromyalgia is different. And this is a problem. We can't pigeonhole them and say this is exactly what's happening, because everybody has different symptoms. So where's the drainage occurring? So this is where scientists like myself have been looking for quite a few years, and we have discovered that the perivascular space, the space around the blood vessels, it contains cerebrospinal fluid, and cerebrospinal fluid drains out from the brain into the lymphatic system. This is my hypothesis of my research. When I published my thesis in 2005, this was never proven. But now we know that this drainage is controlled by two areas of the brain, the hypothalamus and the locus coeruleus axis. So this whole area, this axis between the locus coeruleus, which produces noradrenaline, and the hypothalamus, which is a major part of the central neurological control of the autonomics, this has been proven to be a major center for the control of the drainage of the brain. And the drainage of the brain has been shown to exist in this area, and not just in the perivascular spaces. This has been shown in 2015 in mice to actually drain into vessels that were true lymphatic vessels lining in the dura of the meninges. So the brain had eventually proven that it has a true lymphatic system lining the brain, draining the cerebrospinal fluid which go along the perivascular spaces into the lymphatic system. However, my work wasn't proven then because I said this was happening in humans, and we didn't have the proof for this till 2017, when this wonderful image, which on the web is three-dimensional, you can see it all around, and there's a wonderful image of a 47-year-old woman's brain, and all the bright green there is lymphatic drainage of the brain of this woman. So what do we do? Well, as osteopaths, we work on the allostasis, the allostatic load, the sympathetic nervous system being completely disrupted in chronic fatigue syndrome, ME, and fibromyalgia, and we have to balance it. So if it's out of line, what happens? What do we see? So we see what's a trauma or a congenital. It can happen in families. Physical damage affecting the perivascular spaces, and these perivascular spaces, the main ones are the olfactory, the optic, the trigeminal, the auditory, and the spinal canal. Also, there's drainage in perivascular spaces down where the spinal nerve roots are. So this is the first stage of problems leading to increased inflammation, increased cytokine activity, or other toxins draining into the brain. And then you have emotional stress, physical trauma, immunological trauma, infections, sensitive allergies, environmental trauma, other pathologies, all increasing the toxic overload in the brain and the spinal cord. And it could be emotional stress, good and bad, via the limbic system, via the into the hypothalamus, and these other areas, the other circumventricular areas. There's hormonal system affecting this area, these areas as well. And external, internal stimuli will all lead to an overload of these chemicals, which become toxic to the brain. And then once the sympathetic nervous system has been overloaded too much, then it's this triggering factor that Professor Younger talked about, this triggering factor, usually a viral infection, and we have a major viral infection spreading around the world, or spread around the world, which can cause sympathetic dysfunction, complete dysfunction, and then you get a backflow of lymph, because lymph is controlled, as we'll talk about in much more detail, is controlled by smooth muscle walls controlled by sympathetic nerves. And therefore, if they're going wrong, if there's a toxic overload to the central areas controlling the sympathetic nerves, you're going to get this backflow of lymph. This retrograde lymph flow leads to further toxicity, pumping instead of out of the brain, which we now know exists, back into the brain. And this causes chronic fatigue syndrome, which leads to the physical signs that I discovered many years ago that are on this slide here. We have long-standing spinal problems, and as I said, we see this always in the thoracic spine with ME patients and fibromyalgia patients. We have varicose lymphatics, whereas the lymph is pushed the wrong way. And we can actually examine we can actually feel them and sometimes even see them. Then you've got tenderness in the lateral, left lateral area, lateral and superior to the left nipple. We have a tenderness in this area known as Perrin's point. I discovered this tenderness, and we see this tenderness in all patients with ME. And also we have a tenderness in the celiac plexus, because that's a big bundle of sympathetic nerves as well. The tenderness in the Perrin's point is explained very simply. It's the tenderness from the sympathetic nerves coming from the thoracic duct, which turns to the left side, just above the nipple line. And we also have a deep cardiac plexus. Remember, it was called irritable heart disease by Da Costa in the American Civil War. There's irritation of the heart, and we're seeing this again with post-COVID patients. There's a lot of heart problems affecting them as well as lungs, and it was the heart and lungs that was what Da Costa saw with patients, the sympathetic nerves controlling it. It's not just a disease in the heart and lungs, it's the control mechanism of the brain. In the brain's control, that's where the toxins are being affecting the control mechanism. So this causes an irritation of nerves in the cardiac plexus area, and where the two areas come together, the cardiac plexus, neurological influence, and from the thoracic duct influence, you get a network of sensory nerves being fired off, causing sensitivity in this area. Likewise, in the fourth area, the celiac plexus, when you've got any abdominal, visceral problems, which you do have with chronic fatigue, often you get irritable bowel and irritable bladder, and there might be a hormonal problems with women lower down, and also aches and pains in the legs, which are very common. All those will cause extra sensitivity around the celiac plexus area. Then there's an effect on the craniosacral rhythm. I put reduction of craniosacral rhythm. It should really be disturbance of craniosacral rhythm. William Garner Sutherland sort of discovered the cranial rhythm, or developed the theories about the cranial rhythm, whereas it was Still who discovered that there was a movement in the cranium, and he did work on the cranial he had cranial techniques from day one of osteopathy, really. But Sutherland developed it into the science that it is today. And he said, when you tap the waters of the brain by compressing the fourth ventricle, see what happens in the lymphatic system. Visualize a lymph node that is holding some poison that has gathered there, changing the constituency before the lymph is moved along into the venous system. Fibromyalgia is finally so we're talking about Sutherland's. Sutherland knew the waters of the brain drained to the lymphatics, as did Still. There was a connection, and osteopathy was based on this, and cranial osteopathy especially. And what we see is with ME, there's a reduction and a dysfunction of the cranial rhythm. And I published a paper in 2007, which was published in the Journal of the American Osteopathic Association, on the cranial rhythm, on the origins of the cranial rhythm. And it is this drainage system from the brain, I'm convinced. As fluid comes out from the brain into the lymphatics, it causes a third, an extra wave. The wave of you've got the circulation, you've got the heart rate, which produces the choroid plexuses, the blood flow in the choroid plexus, which then produces cerebrospinal fluid, going back to the venous sinuses. So within the brain itself, cerebrospinal fluid has a rhythm of the cardiac rate, that 50 to 100 beats a minute. This is accepted in neuroscience. But as it drains now off into the lymphatics, the thoracic duct and has a pumping mechanism controlled by sympathetic nerves, controlling the smooth muscles of the thoracic duct. And this is around 4 beats a minute. When you have a 50 to 100 beats a minute going down, hitting another wave of 4 beats a minute, the two waves crash together, come together, and it causes a third wave, and that's called in physics the interference wave. This theory of waves and the production of a new wave is accepted science. You don't need to be a physicist to understand it. Just have been to a beach. You've been to a beach, you'll see a big wave coming in, small wave going out, they crash together, producing this third wave. And the third wave in our bodies is the cranial rhythm, produced by these two waves. Because we know the connection between cerebrospinal fluid and lymphatics. So this causes a reduction in a problem, dysfunction in the cranial rhythm that we can see quite clearly in chronic fatigue syndrome, ME, fibromyalgia, and many other neurological problems. Fibromyalgia has been solved. They actually looked at the sympathetics more detailed. They did a biopsy and showed that the arterial venal shunts, which control blood flow in the hands and the feet of people, they're often affected quite badly in fibromyalgia. So you get the pain in the hands and feet, but you also get a change in the blood flow, and also you get a change in sympathetic nerve activity. So they found that the sympathetic nerves were very much related to the sensory component. And this is where one of the rationales behind the Perrin's point and the celiac plexus tendons. There's an overload of sympathetics as well as sensory components. So when you examine patients with chronic fatigue syndrome, there's an international consensus criteria looking at symptoms and how long you've got it for. They used to have a 6-month waiting. Now they rely on clinical judgment. But the main thing that with chronic fatigue syndrome is post-exertion neuroimmune exhaustion. So we don't need to wait 6 months like we used to have to wait. If you followed the international criteria of the past, the Canadian criteria, and so we can get to patients very quickly if they're starting for post-COVID syndrome. If they start the symptoms early on, you can examine them, and the physical signs are there. are there often before they actually have the virus or have any post viral disorder. They will have the physical signs there, and this is where osteopathy comes in. We can actually examine the patient and look for these physical signs. So what toxins are there? There's yeast, bacteria, viruses, parasites, pesticides, heavy metals. There's lots of different possible toxins, poisons affecting the brain, affecting the nervous system. And in research at the University of Central Lancashire, where I'm honorary research a senior lecturer there, and at the Manchester University, plus working with the NHS, we did a study which was published in the British Medical Journal, the BMJ Open. The question we asked was, can physical assessment techniques, the physical signs, aid diagnosis in people with chronic fatigue syndrome, ME, myalgic encephalitis, a diagnostic accuracy study? And this is a citation for the paper. And we showed basically that you can, and we'll go into details of the research, but we showed that practitioners following the protocol that I developed were 86% success in diagnostics compared to a 40% diagnostics for diagnosing ME from a consultant using standard neurological and rheumatological clinical methods, like reflexes and doing certain tests on how they move and how they stand and how they look. And it shows that you can't tell from just looking at the patient if they're ill or not. But if you're using the physical signs, we showed a very high success rate. So the treatment of ME using my techniques, the Perrin technique, we use cranial techniques, we use lymph drainage techniques, and basically the principle behind the treatment is the concertina effect. So stimulating the lymph to go up to the subclavian and down to the subclavian. So we use lymph effleurage techniques, pushing the lymph up towards the subclavian area and down towards the subclavian area, using gentle muscle stretching, gentle massage work, gentle cranial. Neurolymphatic disorders for the Perrin technique is for neurolymphatic disorders, not just for ME. There's other conditions, and we think syndrome will be one of these. Developed in 1989, the Perrin technique is an osteopathic approach that manually diagnoses and treats disorders affecting the neurolymphatic system, such as CFS, ME, and fibromyalgia. The drainage of toxins from the central nervous system via cranial, articulating and effleurage of the head, neck, back, and chest is directed by the practitioner, while the lymphatic system via the lymphatic system into the blood, where the offending toxins are detoxified in the liver. Eventually, with less poisons affecting the brain, the sympathetic nervous system begins to function correctly, and health is eventually restored. We did research for many years at the University of Salford and Manchester University to examine exactly what's happening in the brain and in the muscles, and we'll be discussing that at the workshop. But post-COVID-19 syndrome, myself and colleagues at the University of Manchester believe there is a potential for a major outbreak for post-viral syndrome to manifest following COVID-19, as previously reported following the SARS, the severe acute respiratory syndrome infection, which was in 2003, also a coronavirus. CFS ME is often triggered by a virus, and it is a buildup of cytokine activities in the central nervous system that leads to many of the post-viral symptoms which we're seeing with post-COVID due to the toxins, i.e. the pathogen and pro-inflammatory toxins passing through the blood-brain barrier in the circumventricular organs that I mentioned earlier, such as the hypothalamus. The neurolymphatic drainage needs to be explored in COVID-19, and I'll be showing how we can treat that, how we can treat the drainage in depth as soon as we can get back to normal, and give you a practical workshop. So the Perrin technique looks at balancing the hypothalamus And it's not just a matter of using techniques. We advise pacing, we advise supplementation, and also, there's a mind part as well that we look at. Not saying that we should go down psychiatric drugs, but you should also look at certain neurolymphatic, certain ways of neurolinguistic programming, NLP techniques, which is very important. And we can help with very gentle talk therapy techniques that can be done by practitioners very simply, teaching the patients how to cope better. And a very good one at the moment is what's known as ACT, acceptance and commitment therapy, which helps the patient cope using a combination of NLP techniques and using more mindfulness techniques and meditation techniques. The ME Association survey looked at the top 25 treatments as expressed by patient preference, and they put the pacing as the first. Pacing is incredibly important, doing half of what you feel capable of doing. So anybody with post-COVID syndrome should straight away start pacing. Relaxation and meditation is incredibly important, and the Perrin technique was voted third highest and this is the 3 parts of basically what we're doing in clinic all the time with patients such as this. CBT and graded exercise therapy are way down on the list. These are terribly way down on the list it's the ones that have been recommended for treatment around the world. Cognitive behavioral therapy is a coping strategy. Graded exercise therapy often makes a patient much worse when they try to increase activity. It's only when they're actually much better then you can start increasing activity. So pacing is so important, but not pushing. The patients we did a survey, and the patients early on in my work, we took 240 patients, and we showed the more female than male. We know why, because of lymphatics building up in the chest, more in women, and hormonal control as well. And also in the cytokine storm that we're seeing with ME, there's a high levels of leptin, which is a female hormone, and this is again another reason why women get ME much more than men. Improved after 1 year. We saw 217 with my treatment. 90% of patients started improving within a year. Some were unchanged, and unfortunately 2 were worse. We don't want anybody to be worse, but less than 1% is not too bad. Relapse after initial improvement. Some of the patients who improved got worse much quicker than we wanted to, because they overloaded. They did too much too soon, and this is where the graded exercise has to be very carefully monitored. Or they got another virus. So we don't want them to get worse. We want them to stay a while, but some did in that year did get worse, and we had to start the treatment over again and improve them. Completely symptom-free, 37 of the patients, that's almost 16%, got completely symptom-free in the time we treated them, and this was a really good. The average of getting completely better from ME is around 4% internationally, and we saw a much more higher, almost 4 times as high. So obviously we want everybody to get better, but we're dealing with a chronic illness, so it's not so easy. And we'll talk about severe patients, and severe patients have other conditions as well, comorbidities such as Ehlers-Danlos syndrome, joint hypermobility syndrome. They might have POTS, postural orthostatic tachycardia syndrome. They might have anxiety and depression problems, food allergies, all other things going on top of the CFS-ME, so we need to work on that. But just to finish off with a patient I saw years ago, she was housebound for 11 years, wheelchair for 2 years before the treatment. 18 months later, Jade and her family and friends and myself went to the top of the highest mountain in England, and that was somebody who was wheelchair bound and bedridden for many years. So we can sometimes do miracles, not always, but osteopathy can help, and my treatment is all based on the principles of osteopathy. This is the paper in the Journal of American Osteopathic Association. This is a reference to it on the cranial rhythm. And this, my book, is still available. Book 2 is coming out soon. We're working on it during COVID-19. And this will be the scientific treatise of what's in the first book, showing how science has caught up to my original hypothesis. But it gives you a good illustration of how to help patients with chronic fatigue syndrome, ME, and it's available online. It's available on Kindle as well as in paperback. So thank you very much. Hope you had a little taste of my work in that half an hour or so.
Oh yeah, there was more than half an hour. It's fascinating. It's very, very interesting. Of course, a lot of questions pop up and curiosity mainly, but unfortunately, it's 10 to 10. You have a patient now in 10 minutes.
I know. I think I heard the doorbell go before, so I think he's waiting in the waiting room. And we can't have more. We try to have one patient at a time. Obviously, with COVID, we're spacing out the patients. So I better go and see him before we have a backlog.
Thank you so much.
Okay, take care. Obrigado. Is it obrigado?
Obrigado. Yes, it's very nice. Hopefully, we'll see you by the end of this year. Hopefully, yes,
sometime maybe the beginning of next year, whatever. As soon as it's safe to travel, I'll be traveling again. But at the moment, it's. But stay safe, stay protected. Remember, one thing, one message for this time is protection is everything. If you have barrier between you and the patient, the more barriers you have, the less chance of getting this cytokine storm of viral overload, and this viral load is what's killing people. So if you reduce that, then if you get the infection, you'll get a small amount, and your immune system will hopefully be able to build it up. So build your immune system up with supplements and keep barriers, and you'll stay safe. Okay, so take care, Bruno, and I'll see you soon. Okay, God bless. Bye.
E pronto, foi assim a conversa com o Dr. Raymond Perrin, interessantíssimo, como seria de esperar. E apresenta a nossa próxima Osteotalks, vai ser com algumas áreas da coordenação da licenciatura em Osteopatia. Isto porque 2020, em breve, saem os primeiros licenciados em Osteopatia. E portanto 2020 é então um marco nesse sentido e será interessante fazermos uma introspeção sobre então o desenvolvimento da licenciatura em Portugal, sobre o desenvolvimento da profissão, com as áreas, no fundo, que estão na linha da frente no ensino da osteopatia, e portanto vamos falar com alguns dos coordenadores das licenciaturas, da licenciatura em osteopatia em Portugal. Nem todos aceitaram o nosso convite, mas vamos falar com algumas destas áreas da coordenação, em breve, Osteotalks, numa data ainda que não posso definir, que não posso dizer, mas até lá fiquem seguros, como dizia o Dr. Raymond Perrin, protejam-se e até breve.